Today, our guest is Dr. SAPTARSHI Chaudhary MD, Professor, Head of Department, Practice of Medicine, and Visiting Professor Mahesh Bhattacharya, Homeopathy Medical College and Hospital, Howrah, West Bengal. A lot of descriptions are there. I'm not going to all these things, but the publication we must pay attention. That is Chaudhary S. and Kudapaksh are deep vein thrombosis cured by homeopathy. Then Mukesh K.S. Ganguly and Chaudhary, homeopathic medicine used as prophylaxis in Calcutta during COVID-19 pandemic. Then another one is homeopathic management of pain and stiffness of arthritic knee joint, clinical data analysis of palliation criteria and observational study. Then another one is traumatic tongue fibroma treated with individualized homeopathic medicine, a case report with brief literature. Then another one is what with burning pain and occasional bleeding treated with individualized homeopathy. A lot of publications are also there, and the subject is approach to cases of anxiety disorder through homeopathy. We all know that this is an era of anxiety disorder. Anxiety is everybody is buried in anxiety. So an important topic on behalf of Ifph, and welcome Dr. SAPTARSHI. You can have the platform for the next 45 minutes. It's over to you. Please proceed.
Thank you, sir. Thank you very much. Let me share my screen.
Yes, okay, you can share.
Need to make it a, this should be just a minute. How to make it a whole screen? Actually, if I can, yeah, if I can make it a, pause share, just a minute.
You can just click on the side screen so you can go through the different slides.
Yes, that is the thing. I'm not been able to do that thing.
Maybe some technical problems are there.
Yeah, maybe.
And no need of anxiety. Take your own time, no problem.
Just a minute, sir. I am not able to do that thing. Okay, whatever.
You can proceed without screen, even without screen share, you can go.
No, I can share my screen, but the thing is that actually I need to make it, the whole screen should be shared. I mean, what I can share it now is resume share. Yes, I think.
Or you can re-enter and start.
Yeah, that I can do.
No problem. First, you please close your screen sharing and then I can start again. Then it may be right.
Yes, sir. Something is actually happening. Let me see if I can.
Where you please close the screen sharing and once again, then you can restart, sir, and it may be better.
Pause share. Yes, I have done it. And now desktop. I don't know, something is actually not working somehow. Whatever. Can you see?
Yes, yes.
Okay. So without wasting much more time, let us go to the thing. As you have already said, sir, it's really true that the era we are right now living in is basically era of this stress and anxiety disorder. And most of the cases we are dealing in our OPD and IPD. Basically, obviously, as we know, our homeopathic hospitals have a very good OPD setting and obviously IPD setting. But the people, those who are coming to us, if we carefully observe them and if we carefully go through the anamnesis, we can easily understand that most of the people coming with some sort of manifestation of anxiety disorder. Now, the thing is that as a homeopath, we have an entirely different set of view to the patients, those who are having to the disease condition, because we do not treat disease condition, rather we treat the person, those who are suffering from disease, that is the sick individuality. The thing that we have to always remember while we are going to treat the patient, because naming the disease, it's okay for, classification of the disease to be at par with the modern era, modern diagnostics, and to be at par with the other systems of medicine. We have to do that thing, but it doesn't mean that we have to walk in their own way. Their way. We have a very good way of our own, and we have to stick to that thing. Now, what is it's a part of psychiatric disorder, so that's why I'll first like to say that what is psychiatric disorder. Psychiatric disorders are such clinical condition which are characterized by some problem where there is where is the problem in the motivation. If there is a disorder of motivation, disorder of emotion, then disorder of cognition, and obviously socialization. Now, initially, since this anxiety disorder is a part of this psychiatric disorder, now with time, actually, the modern medicine, what they do, they usually change, and they usually, change their classification of their mental diseases as per, obviously, they classify through their ICD-10. Right now, there is ICD-11, and there is DSM-5. And the present classification of mental disorder through DSM-5 is like that. And obviously, we know this classification changes from time to time. But for our own practice, our own clinical practice, what we can do, we can simplify this kind of mental disorder. Obviously, not according to the Hahnemannian way, but for the sake of diagnosis, we can at least simplify that thing into like this: anxiety disorder, mood disorder, disorders of childhood and adolescent, somatic symptom disorder, feeding and eating disorder, personality disorder, schizophrenia, and mental health problem. But among all these things, I have very purposefully written that anxiety disorder on the top, because most of the patient, as I have already told, those who are coming to us are suffering from some manifestations of this kind of anxiety disorder. And obviously, mood disorder and other disorder, these are also there, but perhaps the most prominent features that we are getting is anxiety disorder. So what is basically anxiety disorder? See, some sort of anxiety is obviously better for sincere performance. Right now, obviously, I'm also having some sort of anxiety because I'm going to present before a learned audience. So that's why there was some sort of a bit anxiety is there, and it is required. Because having that kind of anxiety, obviously you will have some, that will be a driving force. But when this anxiety is actually, with the anxiety, the ease of life is lost, then that condition is a disorder then. So if there is a persistent or excessive, uncontrollable, and unrealistic worry, which is apprehensive expectations, as we can say, about a number of events or activities of life, if such thing actually happens, then we can say uh, that the person is suffering from a disordered condition because of anxiety. So this persistent, excessive, uncontrollable, and unrealistic worry is a key factor. Now, if we look at the present scenario in our country, the depression and anxiety disorder, they are cropping up like anything. Perhaps they're increasing in each and every day, and most of the people, and the even the youth, even the children, they are a large number of population, they are suffering from this anxiety disorder. If we look at the anxiety disorder prevalence by age, right now it's in 2019 data. If we see the age prevalence of anxiety disorder, we can easily find out that people, those who are in the even early, you can see the early
Some technical problems occurred. Unfortunately, our guest is now not in the participant list, so we must wait. Yes, he's again there. He's there.
Yeah, thing is that actually I lost, the connection was lost.
Yes, sir. No problem. Disposition.
Yeah, can I share my screen? Yes, is my screen, can you see my screen?
No, not started, sir.
Okay.
Yes, started. Okay.
Can you see my screen, sir?
Yes. I think slide number 8. Yes.
Yeah, can you see?
Yeah, right.
Oh, okay. What I was talking about, the pre-COVID and post-COVID era, it has, the entire thing has been changed. I mean, even we can see the anxiety disorder is prevalent, is much more. I mean, the COVID scenario has entirely changed the world. I mean, a world, and the anxiety is perhaps the most prominent symptomatology, or the most prominent thing which we have observed during the period of COVID, and the social distancing, and I mean, the panic of a disease condition, and all these things actually, a huge number of population, they actually suffered from anxiety disorder, pre and during the time of COVID, and obviously post COVID scenario. Now, why this kind of anxiety disorder is there? There are so many theorems, and so many analytical we pathway, we can say. We can say that the brain amygdala appears the key modulating factor for the fear and anxiety, and obviously there's a heightened amygdala response to anxiety cues and the hyper responsiveness. These are the theory, but I'll rather concentrate my I mean saying, or my presentation in a homeopathic way. uh, Now, the anxiety disorder was previously classified in that scenario. The anxiety disorder was the most prevalent as of all, as I have already told. The 15 to 20% of medical clinic patients, they were suffering from anxiety disorder, and they were basically characterized by subjective sense of unease, dread, and foreboding, and it can be primary or secondary to the other medical condition according to the DSM-4, and it was classified into this panic disorder, generalized anxiety disorder, phobic disorder, stress disorder, and obviously obsessive compulsive disorder. But right now, this anxiety disorder classification has been changed. The anxiety disorder now includes now, what is basically anxiety disorder? The anxiety disorder includes a disorder that shares the features of excessive fear and anxiety, as I have already told, and related behavioral disturbances. And this disorder include, now according to DSM-5, it has classified separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder or social phobia, and obviously agoraphobia that we say, and the panic disorder, various kinds of panic disorder, and generalized anxiety disorder, substance and medication induced anxiety disorder, and anxiety disorder due to another medical condition. Now, this obsessive compulsive disorder, which was a part in this DSM-4, now it has been removed. And the acute stress disorder and PTSD, the post-traumatic stress disorder, included in the trauma and stress-related disorder, not in a part of this anxiety disorder right now, and are no longer considered as anxiety disorder, as I have told you in case of DSM-5. Now, so with time, these things actually changes. So, but we have, being a medical profession, we have to have the cue of this thing. What are the changes that are actually coming in a DSM-5 or this thing? But again, I will say that we would rather concentrate on the classification of mental disease as per the Hahnemannian way, as it has been told in the organon of medicine. Why? I'll come to that. I'll say that. Now, the prevalence of subtypes of anxiety disorder right now in our country is basically the generalized anxiety disorder, panic disorder, school phobia, separation anxiety disorder, social phobia. The school phobia, separation anxiety disorder, social phobia, these were there, but it has grown post-COVID era. Now, I'll rather say that these kind of anxiety disorder, I'm taking some time. Why? Because first we have to understand why these kind of anxiety disorder are generally growing. See, if we look at the social perspective, our society, the Indian society, is changing very fast. See, we are just following the European society or the American societies. Our families were not like that. Now we are living in an age of nuclear families. Most of our family members, they are getting separated from their parents, and obviously because of the socio-economic condition, now both the parents have to go to job, for earning monies, and the children, either they have to be there in a creche, or if they are solvent enough, they can hire a person who can look after the children. In our ways, when we were children, we used to live in a family where there are so many family members. We have different cousins and sisters, and so many people were there, those who used to take care of ourselves. Right now, because of nuclear family, one child policy or two child policy, now these kind of social distancing and all these things actually, uh, people are not getting time. And again, beside that, the another thing, that is the mobile phone. We don't have time to talk to each other. We don't have a time to physically meet people. We don't have time to spend our time together. We don't have our time to share our emotions with each other. So these are the things actually separating ourselves, or these are the things which are actually creating boundaries, and these are creating cocoons around us. And these are perhaps the most possible pertinent causes for developing anxiety. Now this anxiety disorder, as I was saying, now among these anxiety disorder, panic disorder is, I'll rather first start with panic disorder. Now this panic disorder is, now there are so many causes, but as per these psychiatric causes, we can say that there is a hereditary predisposition is there, and obviously there is a familial aggregation we know in case of panic disorder. And obviously the monozygotic twins, they suffer more than the dizygotic twins. And there is a theorem of altered autonomic responses. It has been seen that genetically inherited neurochemical dysfunction that may involve the autonomic imbalances and decreased GABAergic tone, allelic pleomorphism of this COMT gene, increased adenosine receptor function, increased cortisol, diminished benzodiazepine receptor function, and then disturbances in serotonin and serotonin transporter, and obviously promoter genes, and then norepinephrine, dopamine, then cholecystokinin, and interleukin 1 beta. Now, faulty social learning. Now, this faulty social learning is another thing, is there for panic disorder. And these patients of panic disorder, they have a very high sensitivity to somatic symptoms. Now, this panic disorder is again for this panic disorder, what an age of onset is typically late adolescent and early adulthood. Why? Because before this age, we usually remain protective in our familial environment, but and at this age, we generally have an opportunity to interact with the outside world. So obviously, some sort of and obviously there are changes, hormonal changes, and obviously neurochemical changes. These things are actually happening this time. So obviously, these actually creates a fertile soil for having this kind of disorder. It occurs in an unexpected fashion and develops in an abrupt manner over a period of 10 minutes and lasts usually for an hour. And lifetime prevalence is 2 to 3%, and anticipatory anxiety and thus avoidance develops over the period of time. Recurrent and unpredictable panic attack have a distinct episodes of intense fear and discomfort associated with a variety of physical symptoms. Now what are the physical symptoms that is encountered in case of this panic disorder, that is a palpitation, trembling, sweating, shortness of breath, dizziness, fear of impending doom of death, or paresthesia, gastrointestinal distresses, and feeling of unreality. Now, this diagnosis requires at least 1 month of concern or worry about the attacks or changes of behavior related to them. So for this, if these symptoms are persistent and if this kind of symptomatology is experienced by one individual and where these symptoms are there for at least 1 month, then we can say that these this particular individual is suffering from panic disorder. Now, if there is a panic disorder, we have to obviously, before labeling one person that he is suffering from panic disorder, even if he has got or she has got that kind of symptom, we have to be very we have to DD that thing, whether the person is suffering from coronary artery disease or MI or PSVT or MVD or respiratory disorder or endocrinal system disorder like pheochromocytoma, thyrotoxicosis, and obviously some neurological condition. It also be mingled with some substance abuse. So we have to be very, very careful while we are diagnosing or we are saying that this particular patient is suffering from panic disorder. The another class which is again very, very important is generalized anxiety disorder. Now, it's a variety of anxiety disorder which is basically characterized by persistent, excessive, and or unrealistic or uncontrollable worry associated with muscle tension, easy fatigueness, impaired concentration, or mind where there is mind is basically going blank. As we know, this just mind head is like empty vessel. We have such kind of symptomatology in different kinds of drugs, and obviously there is autonomic arousal and feeling of age or restlessness, insomnia. If these kind of symptomatology are there, and if 3 or more of these symptoms are there persistently for at least 6 months, then we label that clinical condition as suffering from generalized anxiety disorder. And usually this, in case of generalized anxiety disorder, the onset is usually before 20 years of age, and there is a history of childhood fear or social inhibition that may be present. Lifetime prevalence is usually 5 to 6% of patients, they have a lifetime prevalence, and risk is higher in the first degree relatives. And interestingly, family study indicates that generalized anxiety disorder and panic disorder segregate independently. Now, in case of generalized anxiety disorder, the following points are to be noted: that more than 80% of generalized anxiety disorder also suffers from major depressive disorder or dysthymia or social phobia. Comorbid like substance abuse like alcohol, sedative, hypnotics, these things are present, and it becomes worried excessively on minor matters with life disrupting effects. I think we all can understand, we all can remember some of our drugs very easily while we see this kind of symptomatology. Unlike panic attack, now this generalized anxiety disorder, the physical symptoms like shortness of breath, palpitation, tachycardia are relatively rare here. And this generalized anxiety disorder is if we current as per the current statistics, generalized anxiety disorder is perhaps of highest prevalence in case of patients those who are suffering from anxiety disorder. Now, the other disorder which I would like to say is a phobic disorder. Now, this class of anxiety disorder is characterized by marked persistent fear of an object or a situation, and exposure to which actually causes immediate anxiety reaction. Unlike the other anxiety disorder, the phobic disorder has a specific variety. The phobic people feels anxiety only in a specific situation, not always. Now, these phobic disorders are now class these phobic disorders, it is we can say that it is very common and affecting 7 to 9% of general population. Female is to male ratio is 2:1. The full criteria of diagnosis is usually satisfied first in early adulthood, but the behavioral avoidance of unfamiliar object or people or situation can be found since early childhood. Heritability is 35 to 45%, and monozygotic twins have a greater tendency to develop phobic attack, that is 23%, over dizygotic twins, those who have a 15% chance of developing this kind of phobic disorder. Now, as a patient intends to avoid places or persons or situations of phobic stimulus, it impairs their occupational and social functioning. And the awareness that experienced fear is excessive and unresponsible at a given circumstances. The specific content of phobia may vary according to the age, gender, and ethnicity. Now, this social phobia, which is now the part of DSM classification, DSM-5, as we are telling, this social phobia is characterized by marked fear or anxiety about one or more social situations, like in which the individual has to is exposed to possible and exposed to possible scrutiny by others. In children, the anxiety must occur in peer settings and not just during the interaction with the adults. The individual fear that he or she will act in a way or show anxiety symptoms that will obviously negatively evaluate them, and persistence that should persist at least more than 6 months. And the fear or anxiety or avoidance is neither attributable to the physiological effects of any substance, that is substance abuse, that should not be there, or other medical condition, or nor any medical disorder. And examples that includes of social interactions, like having a conversation or a meeting with unfamiliar people, being observed while eating or drinking, and performing in front this social phobia. Uh, Apart from the social phobia, the other different phobias that we encounter during our clinical practices is, now, so very often we can see the claustrophobia, the fear of closed space. We know, and there are some drugs there we usually prescribe. Then there is hemophobia, that means fear of blood. Then acrophobia, the fear of spider. And then ophidiophobia. Then agoraphobia, that means a fear of panic attack in public. Now, this agoraphobia, and we have to be very careful regarding this. With the agoraphobia, one is agoraphobia and one is there is a social phobia. Agoraphobia, that means a fear of panic attack in public, where there is a huge gathering, where there is the public gathering is there, the patient is extremely afraid to go out in such places, like which we get in term like in case of aconite also. Now, my phobia, fear of germs. So these are the specific types of phobia. Am I audible, sir?
Yes, sir, please. No problem.
Can you see my screen?
Yes. Suppression anxiety disorder.
Okay. This is causing clinical significance or other important areas of functioning. The disturbances is not better explained by any other medical condition. So separation anxiety disorder, we can see separation anxiety disorder is is very prominent nowadays. Why, as I was telling, in case of nuclear families, or where both the parents are actually working outside, while the child has to be there with someone else who is not a part of the family, or they are being taken care at the creches. in those cases, separation anxiety disorder, actually we can see the people, these kind of children, those who are coming to our OPD, and basically those people are doing in the IT jobs, IT professional, their children mostly develop this kind of separation anxiety disorder. And also in case of adult separation anxiety disorder, after if there is any kind of history of a relationship crisis, or if there is mostly in relationship crisis. Now nowadays relationship crisis is very prominent in adult age group, no? So this kind of separation anxiety disorder we can find this kind of people. So recurrent excessive distress when anticipating or experiencing this separation is there. Worry about losing a major attachment figures, or about possible harm to them. Worry about experiencing an untoward event. Persistent reluctance or refusal to go out is a very prominent symptom. Excessive fear of or reluctant about being alone. These people, they don't like to live alone. Persistent reluctance or refusal to sleep away from home and without being near or major attachment figures. Now, repeated nightmares is another prominent symptomatology of this disease or disorder. Repeated complaints of physical symptoms like headache, then stomachache, nausea, vomiting, and this kind of symptomatology is very prominent in this kind of patient. Now, separation anxiety is why this kind of separation anxiety disorder is basically there. Now, the changed environment and the stress, obviously, as I was saying, overprotective parents, family members with anxiety or other kind of mental disorder. And separation anxiety disorder is again found in case of where there is the family trouble with single mother or single father. A child is upbringing is being is taken care with by a single mother or single parent. There is this kind of or divorce, increased number of divorce nowadays. Now this kind of thing is actually creating separation anxiety disorder in case of children. And obviously in case of adult, as I have already told, that because of the changed socioeconomic condition, changed environment, need of life, now because of this thing, so fast life, fast pace in our life is actually creating problem in case of keeping relation with each other. So that is why, and we are mostly where the person is mostly emotionally dependent on each other, so these kind of people, they usually suffer from separation anxiety disorder. Now there's a selective mutism is another condition. Now these kind of mostly found in case of children. These people, those who are suffering from selective mutism, they usually do not they what they portray while they are in an environment which is not familiar with, or in an environment to which these children are not familiar. Like if there is a is a certain social situation, or they are going to in a school, they are not talking, they are not, they can easily communicate with their parents, with their known persons. They can easily communicate at their home, at their I mean with the person those who are familiar with. But when he is outside, there's a failure to speak in certain social situations despite the ability to speak, which is very important, and in more comfortable situation. Now, like a meeting with new people versus home with family. In home with family, they can speak very well, but while they are encountering a new people, they are not speaking. Now, use of gestures instead of saying, they are using more of a body language. Okay, where instead of communicating verbally, they are communicating with body gestures, or non-verbal communication. Now, like in case of heightened anxiety with expectation to speak, and obviously there is an intense distress that increases with routine activities and relationships. These are things are there. And according to DSM-5, the persistent failure to speak in specific social situation but freely with others, in others condition, that means the conditions to which the child is familiar, if that thing is there for more than 1 month, then we can say, according to DSM-5, this particular person or child has selective mutism. So it is a rare anxiety disorder. That's why we really don't get this kind of children very often. But yes, we do get. Now selective mutism, another I'll say there, it's not selective mutism, but sometimes people or the children, those who are exposed to different types of languages, this I'm saying from my clinical experience. We usually see children from in whom the parents are, I mean, doing the transferable job, or in whom the child are or the in whom the parents are basically from IT sectors, those who are coming to our hospital. There is a problem. The different language problem is there. See, I can explain the situation like this. This perhaps the children's mother, child's mother is Maharashtrian, father is obviously a Bengali, and obviously why when these two people are talking with each other, obviously they are using another language of communication like Hindi in home, while they are talking with people, those who are coming to their home, they are using another language, Hindi. Or independently, when they are communicating with the children, either the mother using Maharashtrian, the father using Bengali, or they are their the grandparents or those who are coming to them, they are using a different language. So child becomes very confused, what language is my own language? And in these situations, I have seen children, they have stopped talking, and they have started using their body gesture, and they have started non-verbal communication more. It's not like that they cannot speak. Usually the parents say that my child used to say, I mean, according, there is no developmental delay, there was talking, there's a monosyllabic word he used to use, or she used to use disyllabic word, and they used to say, but suddenly he has talks I mean stop talking, because in school he is or she is speaking English, at home she is getting different kinds of language. These kind of thing actually happen, but this is not selective mutism. This is perhaps the child becomes very much confused what language he or she should pick up. But this selective mutism is such when the children can speak freely at home with his parents or those who are there in his family. But when this particular child is put outside, there he is under trouble, he is not able to speak, he is not free to speak. That is a condition we say it's a selective mutism. Now, now there's an anxiety disorder prognosis. The high rate of comorbidities are there. Obviously, the morbidity or mortality through neuroendocrinal, neuroimmunomechanical, neuroimmunomechanism, or direct neural stimulation is there. There is an increased risk of various kinds of diseases like cardiovascular diseases, various kinds of, the most important thing is that because of this anxiety, nowadays we can see this social phobia, social anxiety disorder result in significant functional impairment, and the severe anxiety disorder may complicate by the situation with suicidal tendency or inclination to suicide. So these kind of thing we can easily see. The panic disorder was associated with suicidal attempt, and the odd ratio which has been calculated, that is 18, is compared to the population without psychiatric disorder. That means the in a population who has this kind of panic disorder, they have a chance of committing suicide 18 times more than people, those who are living in a population where there is no psychiatric disorder. So the acute stress may play a role in producing suicidal behavior, and the presence of any anxiety disorder, phobia included in combination with the mood disorder appears to increase the likelihood of suicidal attempt compared with mood disorder alone. So the what actually it means, that the anxiety disorder itself can cause any other corporeal disorder, like cardiovascular system disorder, like endocrinal disorder, like a the neuroendocrinal disorder, or a neurological disorder. Or the most important that we must concentrate is that because of this anxiety disorder, the mood disorder is there, and in mood disorder there is a the depressive mood disorder. And this depressive mood, those who usually suffer from depressive mood disorder, they have a very high risk of developing this suicidal attitude and suicidal, and the committing suicide. So that is why this anxiety disorder is very, very important. And obviously, apart from any other thing, if we can treat the anxiety disorder very in a very early phase, or we can get this anxiety disorder very early phase, we can very effectively treat that thing. Now the thing is that DSM-4, DSM-5, so many things, so many differentiation, so many varieties of symptomatologies are there. The symptomatologies are usually changing with time. We are labeling the disease condition, we are adding something with time, we are discarding something with time. But if we really want to treat this mental disease homeopathically, we have to go to the organ of medicine, our Bible, from aphorism number 210 to 230. In these aphorism, our master has explained this disease condition in elaborately. And everyone knows this kind of disease condition. These aphorisms, aphorism 2000, 200, 215, 216, 2, and obviously then which is this is actually, we say it's a somatopsychic disorder. And obviously there is a this 2200 221, which actually deals with the mental disease suddenly appearing as an acute disease. And obviously 224, where there is a doubtful origin, whether it's because of the corporeal disease or it's a psychological disease entirely, or then it's a psychosomatic disorder. 5. Now we know all these things, but why I have kept these things is that whatever we learn from practice of medicine, whatever we learn from psychiatry, but we have to assess that thing, we have to perceive the entire mental disorder or anxiety disorder in this way. Otherwise we will not be able to treat these cases. Now, since there are I'll discuss my cases. I know I cannot give the details of my cases because uh, 2 3 reasons. We have some cases in pipeline for publishing, and we do not I do not have all these cases where I cannot have the written concept.
Excuse me, sir. How much time you need, sir?
But I'll say this thing. Uh, yes, sir.
How much time you need, sir? We have to finish by 9 o'clock. We
Excuse
want
me.
a discussion for 10 minutes. I think if more topic is there, you can have another session. What is your opinion, sir? Am I audible, sir? Am I audible, sir?
Hello.
Unfortunately, the network is not proper to our, just his audio is not connected now.
Hello.
Yes, sir, please. I think your audio is not connected now.
Hello.
Yes, sir, audible. Please proceed.
In a very short, we don't. I'll within 15 minutes. Obviously, I'll try to discuss all these cases. It's it's a bit old child. She was taken to us while she having was there in every morning. Why was suffering from 2 years at a stretch. She was by various kinds of pediatrician and various and other doctors. And obviously after doing a lot of taste and everything else, everything was normal, nothing pathological was there in that child. But she was taken to a homeopathy hospital. And it is our while we are examining a child, it is very important as a clinician to develop a rapport with the child. It is extreme. You cannot communicate with the child if you cannot bridge the, if you cannot mix with the child uh, as a child, so that he or she can develop a confidence on the doctor. Until unless we can do that thing, obviously he or she not, the patient will not open up to us. And that is why we say, Dr. Kent has said, a well taken case is half cured. So while examining that thing, what we found is that the child was under the situation was that the child was getting ready in the morning. She was having her breakfast. While she was entering into the school bus, she used to throw up everything what she have taken in the morning. But on Sunday, on holidays, on other days, she do not do that kind of thing. Her mother told us she never vomits out, she never throws up while she was going outside during the holidays, while she was riding a bus or riding a train or riding a car. While she is not going to school, she is not having any such thing. After asking the child, what we found that that particular child has separation anxiety. She was extremely afraid while she was going to school, because of one, she was not there with her parents. And obviously the school teachers, they were, one of the school teacher was very strict, and she was scolded one day, and following that she started that thing. And the drug which actually was given was sulfur. This why sulfur was given, obviously this is a symptomatology of the flaring of the sora. And the symptomatology, obviously sulfur symptomatology, we all know what the symptomatology of sulfur, so that's why I have not put all those symptoms. So she was given sulfur 202 doses, and that dramatically scenario, she stopped vomiting. And obviously, apart from giving sulfur, we advise that the parent to go for a counseling, parental counseling, not the counseling outside. And obviously we ask the parent to communicate with the school people, so that she can feel free at school. And obviously what we have asked the parent, that they should give some more time. If they cannot, then obviously the grandparent should give more time, and she should feel secured. And obviously after giving sulfur 2 doses in 2 consecutive morning, there was placebo for 6 months, and thereafter we gave her sulfur 1 mg. And since that, she never throws up. The vomiting was completely gone. Another case was there. It was Mrs. TC, and a 72 years old person. She's a retired school teacher, and she came with the symptomatology of effort dyspnea and heaviness feeling in the central chest. The TMT was positive for coronary artery disease, but I was negative, and coronary angiography was done. It was negative, but the USG of whole abdomen, it was obviously within normal limit. There was nothing else, and she was diagnosed as suffering from microvascular angina or syndrome X. Now, why she was having that kind of thing, when we asked her during the time of discussion, we found that she had not a very good relationship with her husband. She was a teacher, but after retirement, she is not allowed to do her the teaching, and she loves to teach, and she was not allowed to do that thing at her home. She is extremely fond of singing. She is not allowed to do that kind of thing. She was not allowed to go for singing. So whatever her suddenly she felt that she is caged in her home. But thing is that she was so modest that when I asked, why don't you say something? At least with discussion, you can resolve this problem. She just told me one thing, that it is my upbringing that holds me back to confront with my husband. So that is the thing that give us the clue of reserved displeasure. And she was given staphysagria. Staphysagria 1 mg was her prescription. And after giving staphysagria, that effort dyspnea, that heaviness feeling of chest was gone, and it is not there. She is still under our treatment. And obviously after giving staphysagria, our constitution was obviously is calcarea carb. We are waiting to give her calcarea carb, obviously, if the symptoms correspond, and obviously we will conclude the case with this any antipsoric, any other antipsoric that will be indicated in time. But the simple staphysagria, the simple that reserved displeasure, that created a stress within her, and that anxiety, that stress, that she is not able to come out, she is not able to do her job, she is not able to live the life in her own way, now created this kind of problem. So this is another anxiety. So this is anxiety giving a somatic symptomatology, and that is the way we homeopath we usually go. And obviously I must say, we all homeopath we should go in that way. Now another case is Mrs. A, 62 years old female, and she was diagnosed to having IBS. She was having this IBS, and since her husband has passed away, and she is very afraid in everything in daily life, and she's very, but actually she was everything was when her husband was alive. She was she didn't do anything else. Her husband used to take everything, uh, inside home, outside home, everything was taken care by her husband. Now suddenly she is at loss, and obviously her children are not staying with her, and she, what she does is speaks about her complaint repeatedly. She changes her topic of discussion spontaneously, and she, if one single symptomatology, she will tell you, when you are encountering the patient, she will tell you 10 times, 15 times, like that, and she used to change her topic. And obviously, because of this great loquacity, is a manifestation of internal anxiety. And depending on that internal anxiety and this great loquacity, changing of topic, and this kind of thing, this great stress, she was given, and from the other symptomatologies, she was given lachesis. And after lachesis, obviously she got some, this IBS was somewhat less. And obviously, following lachesis, we had, as the symptom corresponded, we gave her sulfur. After giving sulfur, she is not having IBS. She is under treatment for last 8 to 10 months. She is not having IBS anymore. She is rather, at least, not that kind of anxious anymore. And what we have suggested, go for yoga, or go for any kind of social interaction with other people, and obviously to create some support, psychological support group, to join that kind of psychological support group, what she has done, and she is better right now. This another is separation anxiety. Another beautiful example of separation anxiety, Master AB is a 6 years male child. He used to suffer repeated attack of fever. His father is a businessman. Whenever his father is going outstation, the child develops fever. When initially the child, the parent came to us, because the mother took the child to ask for fever, we have seen, we prescribe all those same the drugs that we usually prescribe in case of fever, but none of them worked properly. Every time he was developing fever, and obviously we go for a thorough pathological investigation. There was nothing else. And obviously, on a proper case taking, what we found, it is his father who told us that whenever I'm going out and he is having this kind of fever, so we gave him ignatia. And after that, marvelously, after that ignatia, the child did not develop fever. Even after, while his father was not with him, beside him, he was going outstation. And obviously, following ignatia, we obviously completed the case with another indicated antipsoric, and he was given calcarea carb. And after calcarea carb, he is free from that kind of fever. And now this child is almost is a 16 years old child, and this time he is going for a board exam. He's not having that kind of fever. He never suffered that kind of fever later. Now another case, so Mr. PD, 56 years male, and there's a complaint of prolonged dry cough for at least 3 months. He used to have this anti-allergic drug by our allopathic counterpart, and there is a history of conflict with office boss. And there's a obviously this is a this we found on the on repeated case taking, and what he came with prolonged dry cough. There was no expectoration and nothing else. IgE was normal. Eosinophil count was entirely normal. Lung was chest extra CXR was absolutely okay, and obviously FEV1 and VCY was normal, and obviously HSCT was normal. Everything was normal, but what he had, this prolonged dry cough, and that actually started after having conflict in his office. And following that conflict, this is another case where we got success with staphysagria. We gave him staphysagria, and after having this staphysagria, he actually came out of this thing. And we have so many cases of anxiety.
Excuse me, sir. We have to wind up now, sir.
Pardon, sir?
It's 9 o'clock now.
Oh, sorry.
Am I audible, sir?
It's 9 o'clock. Yes, am I audible, sir?
We have another session at 10 o'clock, sir. Am I audible, sir?
Okay, we have. Yes, you are audible, sir. Sir, okay, one last word. This is last case. This I have seen today itself. There's another case where there is a recurrent, attack of hematospermia, and the patient he has this extreme anxiety, and it is under treatment. And after having sulfur, only sulfur, this patient is improving. And obviously, we are documenting all these cases, and we have a plan of publishing these cases in near future.
Thank you, sir. Think it's time to wind up the session. Sir, am I audible?
Yes, sir.
Sir, am I audible? Dr. SAPTARSHI? Sir, am I audible?
Hello. Yeah, Dr. Manoj, you're audible. Now I can hear you.
It's time to wind up our session now. Dr. SAPTARSHI, sir, are you there?
Yeah, can you hear me?
Sir, it's time to wind up our session, sir. We have to start the session at 9 o'clock, sir. Please conclude, sir.
Okay, sir. Okay.
Sir, am I audible?